Great, I am recording.
All right, fantastic. So thank you for joining us to discuss the management of severe range hypertension. Ivy and I will be presenting not only the system, but also the specific process at Northern Westchester. So this is just a quick reminder, of course, of the different types of hypertension, and this is based on ACOG District 2 definition: chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia, and of course, our bread and butter and what we really focus on right now is preeclampsia with severe features and what it entails. And we will go into a little more detail. So here are, first of all, the Northwell guidelines for severe hypertension in the obstetric patient, and this is what we actively use at North Shore University Hospital. Our definition, and again, based on ACOG District 2, and then the Safe Motherhood Initiative project, which most of us were involved in a few years ago. The definition of severe hypertension is a systolic blood pressure of equal to or above 160, or a diastolic blood pressure of equal to or above 110, and both of them do not have to be present at the same time. So when that happens, what do we have to do? We have to be ready, we have to recognize, we have to respond, and we have to report. And that means repeating that blood pressure every 5 minutes for 15 minutes. So that will be 3 measures, and notify the MD after one severe BP value, and really consider treating after the second elevation. So hypertensive emergency is basically the persistent severe hypertension. So you either have systolic values of 160 or above, or diastolic values of 160 or above. And the 2 BPs basically have to be taken 15 to 60 minutes apart. They do not need to be consecutive. One blood pressure can be at 5 p.m. and then the last one at 5:40, and that still counts. It's within that hour. And if more than one severe blood pressure, more than 15 minutes but less than 60 minutes apart is noticed, then please initiate treatment. And this is our standard algorithm for the treatment of severe range hypertension, and that is the algorithm that we use, of course. And just a quick note that the onset of action of nifedipine is about 20 minutes, and the half-life is 2 to 5 hours, and the onset of nifedipine XL is about half an hour, with a peak plasma time of 6 hours. So it has a longer onset as opposed to IR, which is 30 to 120 minutes. So what does it entail for us? If you have an isolated severe range blood pressure, if the repeat is not in the severe ranges, then typically we continue to monitor the patient for 15 minutes times 1 hour, and then 30 minutes for another hour. And if the blood pressure is less than 140/90, then we typically resume the routine vital signs. And if the BP is out of severe range, then you do have to monitor that patient Q10 for 1 hour, Q15 for another, Q30 for another hour, and Q1 hour for 4 hours until we are satisfied that that pressure is back to normal. And of course, we do have to take into consideration the fact that if that patient starts spiking severe range blood pressures, then we do have to collect labs, which include CBC, platelet, LDH, of course, liver function tests, electrolytes, BUR. Sorry, 1 second. My Alexa activated itself. Creatinine, and urine protein. So some of the considerations, our goal, of course, is to ensure that patients' blood pressure is between 140 to 150 over 90 to 100, especially if they were previously in a severe range. We don't want to drop that blood pressure too dramatically because then it will destabilize the patient's hemostasis, and then that would affect the fetus. So in hypertensive crisis, maternal stabilization really should take priority before we consider delivery, even in urgent circumstances. And the reason being that if you stabilize mom, typically the baby will stabilize with. And recent evidence also supports pionafetapine as it being more expeditious at lowering BP than IV labetalol or hydralazine. I just wanted to emphasize that at the end of the day, it really is a physician's preference, a provider's preference as to which line is used as a first line. IV hydralazine may increase the risk of maternal hypertension, and IV labetalol, of course, may cause neonatal bradycardia, and it really should be avoided in women with active asthma, heart disease, or congestive heart failure. And what does active asthma mean? Active asthma, according to ACOG, is basically a patient who has symptoms at least once per week, or uses an inhaler or corticosteroid during the pregnancy, or has a history of intubation or hospitalization specifically for asthma. And so it's really important to discuss the risk and benefit ratio with that patient before actively using the labetalol if she has asthma. And of course, procardia is associated with increase in maternal heart rate and less hypotension. So magnesium sulfate is the drug of choice for seizure prophylaxis and to control the seizures in the case of eclampsia. And typically, I think we use the same rules across the board with the bolus. And if that IV access is not actually available once the patient is here, there's also the option of doing an IM injection in 5 milligram IM in each buttock. I have seen it done before during an emergency, and especially if the patient is a heart stick. So that is an option that we can consider. And of course, the indications: severe hypertension, renal insufficiency, unremitting headache, visual disturbances, basically anything that triggers us into thinking that this patient may end up having a seizure. And the contraindications, of course, are pulmonary edema, renal failure, and myasthenia gravis. And other anticonvulsant to really keep in the back of our minds as additional tools for patients who develop eclampsia, and really for the management of recurrent seizures when that patient is not able to receive magnesium sulfate. It just has an FYI. So we have lorazepam, diazepam, phenytoin, Keppra, and of course, as always, clinical judgment really will determine the path of care. So pitfalls of evaluation of preeclampsia. Some of what often occurs when we have a patient who presents is, there might be a failure to recognize the multisystemic nature of the disease. We can have one or two things that are isolated, and we're not considering the full picture simply because we might not necessarily recognize the multisystemic nature of the disease. And then preeclampsia is really, it's a very dynamic process. A patient may present with normal lab values and normal blood pressure, and then all of a sudden everything changes. And mild preeclampsia really should not be considered a final diagnosis, should not really be considered diagnosis at all. And severe features really should qualify the patient as having preeclampsia with severe features diagnosis, which is now the correct terminology. So triggers for bedside evaluation. What really should we look for whenever we have a patient who comes in and she starts to have symptoms that we are suspicious for? If that patient presents with headache, it might signify the progression from mild to severe disease. And of course, visual disturbances, change in mental status, significant abdominal pain, of course, a severe range blood pressure, systolic or diastolic, shortness of breath, or tachycardia. And again, that could also be a host of other differentials, decreased urine output, and abnormal coagulation studies. And of course, one of the last signs is seizures. So this box represents the indicators that qualify preeclampsia as having severe features. So of course, the severe range blood pressures and thrombocytopenia. Here they're mentioning platelet counts less than 1,000, but typically I have seen cases where the patient has a significant drop in her original platelet count. It's not necessarily 1,000 or under, but it's a significant drop from her original platelet count, so that counts. And of course, impaired liver functions indicated by abnormally elevated blood concentrations of liver enzymes, typically twice the normal concentration. But again, really anything that signifies a change from the patient's baseline at admission should be considered. And the progressive renal insufficiency, pulmonary edema, or new onset of cerebral disturbances. So this was one of the handouts that we received during the implementation of the Safe Motherhood initiatives, and it's really an indicator on how to take the maternal blood pressure, and this was based on evidence-based procedures where they trial different methods, and this was the one that proved most effective in capturing the correct blood pressure. So there's recent research that's coming out that shows that preeclampsia may have long-term health consequences, and it's pretty much based on studies that show that women with pregnancy-related hypertensive disorder appear to be at increased risk later in life, and those risks include hypertension, chronic hypertension, cardiovascular disease, renal disease, ischemic heart disease, stroke, diabetes, and the risk is particularly high if 2 or more pregnancies were affected by early onset that necessitated delivery before 34 weeks. And this is actually a large study that was done in 2019 in JAMA, and it was a new mom to be trial where they identified 4,484 low-risk primiparous women and hypertension disorder of pregnancy and indicated preterm birth, and both were present. So this basically showed that the risk of hypertension let's go back here. The risk of hypertension is significantly increased in 2 to 7 years after delivery for moms who present with severe range blood pressure and preeclampsia. And this is an additional study actually precedes the New Mom 2 study, and it was a systematic review in 2017. And again, the same determination was made that there are indicators that show that there are long-term sequelae in the future for women with preeclampsia. And so just a quick look at the potential mechanics. When you have a patient who has hypertension, obesity, dyslipidemia, insulin resistance, and then in pregnancy you have an SGA infant, you have preeclampsia, miscarriage. It really shows that there is evidence that shows a correlation between all these items and these triggers, and then later on developing CVD. So again, some of the risk factors for cardiovascular disease are obesity, family history, hyperlipidemia, and the big one is a history of preeclampsia. And 80% of these CVD is potentially preventable with early attention and intervention. And actually, we recently implemented the cardio-obstetric programs where a lot of our patients who come with, preeclampsia with severe features, and whether it's the first time or especially with recurrent issue, we do refer them to the cardio-obstetric program, and that basically includes a cardiologist who will then follow that mom and ensure that she has, if she needs to be put on medication, she has the right medication. If she needs to have an echo, she has an echo, and basically really follow her postpartum and beyond to ensure that if there's any potential for developing cardiovascular disease, we catch it early on to prevent severity. And now I will leave the floor to Ivy.
All right, thank you so much, Ariane. So essentially, what does all of this information mean here at Northern Westchester Hospital? So we're going to review two of the policies that tie this all together, one of which will follow after this. So management of severe range blood pressures. I'm going to take control, Ariane, from you. And so the two policies here at Northern Westchester are management of severe hypertension in pregnancy and magnesium sulfate for the treatment of preeclampsia, Eclampsia guideline. And so Policy Tech is not an easy platform to navigate here at Northern Westchester to easily access our policies. And so what I found easier is when you double click on your Policy Tech, you can go over here into the search engine and just write magnesium sulfate. And if you scroll down just a little bit, you're going to get all three magnesium sulfate policies. But today we're focusing on two, and the one in bright red is what I'm going to follow up with next. I know this isn't again, an easy platform, but this is the easiest way I could find them for you with the least amount of clicks. And so management of severe hypertension in pregnancy. Our policies follow a quite easy format to read. It always starts with a purpose and a policy. And what's nice is that afterward follows typically definitions. And so everything that Ariane just explained in a nutshell is included under the definitions. And so you'll see that a hypertensive emergency is severe hypertension that persists for over 15 minutes. And your severe features are outlined under E1, and it outlines all of the other things that you can have severe preeclampsia with and not necessarily proteinuria. So you don't need to have proteinuria to classify a patient as preeclamptic, but you can have the diagnosis be further solidified by either one of these symptoms. Note that in the entire policy, there is no wording of mild preeclampsia. So the reason why ACOG removed that from terminology was because it led people to believe that someone was a little sick. And so with preeclampsia, you either have it or you don't. You don't have a little bit of it. And so over the disease continuum, we just need to figure out how severe it is so that we can better understand when to intervene and manage. The next following portion in that policy is procedures. And though it literally is almost like a recipe cookbook guide on how to approach severe range blood pressures. And so, for example, letter A, it says all pregnant or postpartum patients with a systolic blood pressure greater than or equal to 160 or a diastolic blood pressure greater than or equal to 110 that persists beyond 15 minutes. And remember, that's a hypertensive emergency, requires treatment. And so over here underneath it, I just wrote 3 steps just to get you through this moment. So take a second and regroup. So what that essentially means is you're going to step 2, recheck that blood pressure. But before you do that, you want to assess. And so, of course, in any certification exam, you're always going to assess before you intervene, but that's actually what we do in real nursing practice as well. So you're going to assess. You want to make sure that you have the right size blood pressure cuff. You want to make sure that she's positioned well and that you guys aren't talking through it. When you recheck the blood pressure, you want to know if she is a viable age because you're going to want to put the baby back on the monitor. And in that interim, to help you sometimes through this moment is to explain what's happening to the patient. I'm sure she's going to appreciate it as well because it's scary for them. It also may lead to perhaps a better blood pressure if you explain before you take that repeat blood pressure on what your next steps will be. So the last page of this policy is going to direct you to algorithms. And so you see here the red arrow highlights letter E. First line medications for severe hypertension include IV labetalol, IV hydralazine, and nifedipine. And at the bottom of all our policies, you're going to have cross references and you can click on them and that they will directly take you to what you are looking for. Um, Magnesium sulfate should be given for managing hypertensive emergencies. And so I bold the should because it doesn't necessarily mean that we have to. And so these documents and policy tech are guidelines, and some physicians may choose to manage their patients a little differently, and that's okay, so long that they also write a note about it. And so if you click on one of those hyperlinks, it's going to bring you to this management of severe hypertension in pregnancy algorithm. And it is very similar to the system one. And the only reason it's very similar, not the same, is because we wanted to, here at Northern Westchester, remind you that with labetalol, you want to avoid it in patients with asthma, just as Ariane had mentioned. And this is a lovely document because it's a one-pager and it gives you everything in a nutshell that you need to know. The very top portion will walk you through that severe range blood pressures and what to do thereafter, including the frequency of blood pressures. And so it actually says there, your blood pressures every 5 minutes for at least 15 minutes or longer until the blood pressure is under that threshold or treated. So once you're treating, you're going to follow either the labetalol, hydralazine, or nifedipine recommendations according to each dose. So for example, if you were to choose nifedipine 10 milligrams orally, you're not repeating your blood pressure until 20 minutes afterward. What's nice about the bottom of this page is it gives you a highlight of anticipated management for the patient. So for example, Ariane had mentioned these baseline labs that you want to draw up. Well, everything she said is actually listed there. It's also going to give you maximum cumulative IV doses. So let's just say she has an event at 2 in the morning and then she has an event at 6 p.m. at night. You want to be mindful of how much medications you're giving her in a 24-hour period, and so on and so forth. I won't go through every single bullet, but this one pager is really awesome to have quite readily available. The next policy I'm going to touch base with you guys is magnesium sulfate for the treatment of preeclampsia and eclampsia guideline. And so same thing, policy tech, you're going to search for magnesium sulfate, and the bright red one is what we would click on. And this is a 6-page policy. So I am not going to go very in depth with this, but I just want to give you a bird's eye view and overview of it. You will see safety measures and contraindications, just as Ariane said before. To not confuse you guys, letter H in this policy is a future goal that we have here at Northern Westchester. So meaning it says in letter H that if in the postpartum period and after 2 hours that the patient, and of course if the patient is stable, the patient can get transferred to postpartum. We are not there yet. So that is a future goal. And so I just wanted to bring that up in case you come across it when reading it in depth. And so again, it's like a recipe cookbook guide. It will tell you how to dose, what to monitor for, how to assess, what implications you will see in your electronic fetal monitoring. And what's nice about the last page is it will tell you what to do if your patient actually sees it. So let's just say we did not do the greatest job at managing those blood pressures, or it could just be that this patient's sensitivity is quite low. So it will walk you through the expected management, and it is administer magnesium sulfate and treat the blood pressure. So you absolutely want to get magnesium sulfate on board with a seizure. On the last page of this policy, it highlights communication and documentation. And it is sometimes challenging to document or get your what occurred on paper effectively. And so by all means, double check with someone, phone a friend. Sometimes it's just easier to write a narrative note, and us leadership here at Northern Westchester, we're here for you. We want to be able to help you in getting the right words in the electronic medical record so that we can tell a story. And when we look back and we're trying to identify what we could do better, we can see all the work that you guys really did at the bedside. And I am now going to hand this back over to Ariane.
I think I lost a presentation. Sorry about that. I'll just re-upload it. Okay. Please let me know when you are able to see the screen again. Okay.
And we see it.
Okay, great. Thank you. Just going to quickly go through the slides and get back to where we were. All right, so this is just a quick illustration of a case of a patient that we had in one of our system hospitals. She's a 39-year-old G1P0. She presented at 29.4 weeks for elevated blood pressure and headache. Her BPs were in the 130s to 150s over 80s to 90s with a single value of 170 over 90. This patient had a history of scoliosis and chronic hypertension, for which she was on Procardia. Her prenatal course was complicated by an inpatient admission at an outside institution, of course, for elevated blood pressures. She received a course of steroids and magnesium sulfate, and her Procardia was increased to 90 milligram per day. History of positive GPS, of course, a BMI of 42.9, which is, again, one of the high-risk values we mentioned earlier. And her EFW was in the 14th percentile, so baby was IGR with abstinent and diastolic velocity, which determines that the Dopplers are already affected by not only the patient's status, but probably the placenta. So the AFI was normal. This patient had been on low-dose aspirin, which is one of the recommended ways to manage a patient who has the potential to develop severe hypertension. But there's really a limit as to the time frame for the period to be effective. So it has to be started, I believe, before 12 weeks or by 12 weeks. And I know Dr. Rochason usually refers to it, the prescription of aspirin in a patient either with a history or someone we're suspecting might be at risk for developing preeclampsia. And of course, her PC ratio was elevated. We typically look to a PC ratio of less than 0.1. The fetal heart rate was category 1, though, which was reassuring, and this patient was not contracting. So that's a very typical presentation of some of the patients that we see come to our labor and delivery units. So how do you communicate that to your physician partner, to your resident, to your midwife, to the provider that's working with you? It's really important to communicate in a way that when you're sending the message, the person receiving the message will see it exactly as you send it, and that will increase the communication level. Not only that, but it will also increase the response to the patient and the identification of any possible issue. So one way that we do that is by doing an SBAR. We discuss the situation, the background, the assessment, and the recommendation. And really the recommendation is the critical part of our SBAR, and sometimes that is one of the actions that is missing when we're communicating our needs regarding a patient. So this is an SBAR example. Postpartum patient, post-op day 1, she was admitted with BPs in the 170 over 101. She received labetalol IV push times 1. During labor and after recovery, her vitals were not in the severe range, and you state the blood pressure, and she received magnesium sulfate infusion. And the patient contacted me, the nurse, because she had a really bad headache. And when I took her blood pressure, these were the vitals. A BP was 190 over 110, and the repeat was 187 over 112, so severe range. So how do you communicate this? It's really important to really emphasize what it is that the patient history is, and then what is the current problem. and specifically the recommendation. You really want to emphasize the recommendation. You would like the provider to come to the bedside so we can intervene and take care of the patient and initiate treatment and everything else that's involved in the care of that patient. So you do the SBAR and you're communicating effectively with your provider and asking them to join you at the bedside for the management of that patient, and there is no action. So either your concern is dismissed or something that is not part of the policy or recommended by the protocols or evidence-based practice is recommended. So what do you do? How do you move forward? How do you make sure that your concern and that patient's care is addressed? Ivy, would you like to discuss the chain of command?
Yeah, so here at Northern Westchester, you're going to touch base with your nursing team because typically when you don't have something go the way, and of course, it depends on the severity of the situation, but typically if things don't go as you planned, you touch base with your nursing colleagues and you wanted to touch base to make sure that you're thinking or approaching this correctly. And usually you will get support from your team where you then escalate to the charge nurse or the assistant nurse manager or educator. Otherwise, if that's also you're not getting the results that you would like, you can then escalate to the nurse manager or the nursing supervisor in the event of a weekend where management isn't here, and you're still not getting the outcome that you desire or anticipate to improve patient safety, you're then going to contact the director. You can then escalate to the OB chair, so on and so forth. So we're going to be very diligent to getting the response that we need to maintain safety for the patient.
Great. Don't forget the fetus. I know it's worth mentioning simply because there are times when we are so involved and so concerned for the safety of the patient, and we're escalating on different levels, and we're trying to manage that patient's blood pressure, especially when there are no severe ranges or she starts seizing, then all our focus is on that patient. But there is another patient that is not necessarily vocal that we also need to pay attention to, and that is the fetus. So monitoring that baby is really necessary, as appropriate for gestational age. If you have a non-viable fetus, then if you check the fetal heart and make sure that there is a beat that is present at the beginning, then the focus will be on the patient. But of course, we still have to remember to check that fetal heart to make sure that it is still present once the patient is stabilized. And delay in delivery is really contraindicated for the benefit of steroid if that patient has really uncontrolled hypertension. We've pushed medication and nothing has worked. If she starts to seize and it's uncontrollable, of course, pulmonary edema, or we're suspecting abruption and she's bleeding uncontrollably with DIC, or if there's really a non-reassuring fetal heart tracing that we are not able to correct with position or fluid or anything else that we have in our arsenal. And escalation. It is intimidating to escalate, especially if you have a provider who is not as flexible and who might be challenging to work with, or who might not be as approachable as we would hope they are. And so it's really important to use your resources. There are policies and protocols in place. Of course, we could always rely on our leadership, as Ivy mentioned previously, and really using your book of evidence-based practice and your policies will be your best bet, because you are working with the evidence and you are definitely supporting your need to escalate. And of course, we are patient focused. We are the patient advocates. This is the reason why we are escalating for the benefit of the patient, to protect that patient. But this is also to some extent a protection of our livelihood. And it's really important to document. We want to do right by the patient, but we also should remember to do right by ourselves. And the only way we can do that is by documenting. And again, I think every nurse has heard this. And if you have not, I will repeat it again. If you didn't document, it did not happen. So this is the second case. Patient is a 31-year-old G3P1102. She presented at 32 weeks with elevated blood pressures and headaches. Her blood pressures were in a severe range repeatedly, but she was asymptomatic, so no headache, no epigastric pain, no blurry vision. She was not contracting, and the fetal heart rate tracing was reassuring. Her uric acid was 6.4, and her protein creatinine ratio was 0.6, about 0.1. She has a history of basically 2 previous cesarean section for preeclampsia. She was on labetalol, and her fetus was IUGR, measuring in the 6th percentile, and then later on in the 5th percentile, and she had elevated urine artery Dopplers. So I wanted to engage us in thinking about the management of that patient and how we would triage her, and what are some of the things that we should look for, what are some of the things that we should pay special attention to, and how would we present that patient and escalate to our counterparts if we're not able to receive the response that we are expecting based on that situation. So if you'd like to join in the conversation, please unmute yourself and feel free to join us. Mary, Leah, if you have any feedback.
Hi.
Hi.
So I'm Leah. I'm a labor and delivery nurse in Northern Westchester. You don't know me, so nice to meet you.
Likewise.
So with this case, I would most definitely call the physician immediately, just because her blood pressures are severe.
Absolutely.
So I would SBAR, this is Mrs. So-and-so. She's a G3P, whatever she was. She's 32 weeks. She's had elevated blood pressures. I would say what they were. She has a headache. She has no blurred vision, no epigastric pain. I would say if she had edema or not, lungs clear or they're not clear. And then I would, go from there. My recommendation would, if you could please come to the bedside. Well, I would say her history, of course, would be she had preeclampsia with her priors. This pregnancy, she had they said IUGR. I would give her labs. I would obviously recommend they come to the bedside, and then hopefully they would treat her. And then it looks as if she would need to be most likely delivered at some point in time in the near future.
Yeah, absolutely. Now,
that's what I would do.
Yeah, that's wonderful. Absolutely. Now, if by any chance the provider is not able to come to the bedside, or you're not able to escalate to the provider who normally takes care of that patient, then what are your other resources that you can benefit from? Who else would you be able to bring into the table?
So the luxury that we have at Northern Westchester is we do always have a safety officer. So there is someone always in-house 100% of the time. They may not necessarily belong, that patient may not necessarily belong to their group, but there is another physician on board. But obviously you would go up the chain of command if needed to, if there is resistance. But in most cases like this, MFM's usually consulted and they're usually treated pretty quickly.
Great. That's wonderful. So there's always someone else who can assist, which is really one of the benefits of being in some of our institutions. We do have the ability to work with a wide variety of providers. And if the specific provider for that patient is not available, then we do have the ability to reach out to other providers who might be on the floor to assist. So That is really wonderful. Now, this lady has a pretty significant history of preeclampsia. What would we recommend for her discharge?
Recommend for her discharge?
Absolutely.
I
Is this
feel like
someone who would benefit from additional discharge when she leaves the hospital and she's sent home and she's stable?
Yes, I'd most definitely think she needs to follow, if it would be with her internist or it would be then with a cardiologist or a nephrologist in regards to her chronic hypertension. Just because if she does plan on getting pregnant in the future, maybe she has another problem going on.
Absolutely. Definitely. And again, we previously discussed the research that shows that this patient has a high incidence of developing severe cardiovascular disease in the future. So making sure that there's a referral for her to follow up with an internist or a cardiologist, and really mentioning that history of the incidence of 3 incidents of preeclampsia with the pregnancy would be really critical to making sure that it doesn't fall through the cracks and have the appropriate follow-up postpartum and beyond. Hey, that's great. Leah, any other comment?
No, not really. I just think, her delivery probably should be expedited. She may not be, it'd be nice to get a dose of steroids in her, but like we said before, we don't need to delay her delivery in that case if it's not, if it's not feasible.
Absolutely. Absolutely. Well, thank you so much for your feedback and for participating.
This was great presentation. I wish there was more people.
No worries, Leah. We're recording. It'll hit the masses.
Oh, good.
Which is really fantastic, having the ability to record and making sure that our colleagues who are not able to join us today can at least have an opportunity to listen to you. So thank you to everyone for all that you do. And we really appreciate you being there and taking care of our patients. And we're so grateful that you chose labor and delivery.
Thank you guys.
Thank you guys.
No, it's absolutely our pleasure. And this is just a very quick, brief survey. If you don't mind, you can use your phone to scan this and then answer the few questions in there. And this will give us an opportunity to look at our process. If there's anything that you feel we need to improve on, we would love to hear back. And also additional topics you might be interested in for the future.
Awesome. Thank you so much.
All right. Thank you very much, Ivy. I really appreciate you working on this with me. And we look forward to seeing everyone soon.
Thank you so much, Ariane. It's greatly appreciated.
My pleasure. Have a great day, everyone.
Bye-bye.
You too. Bye-bye.
Bye-bye.